Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections. Today, we are investigating a pathogen that, well, almost every single human on Earth will catch by their second birthday.
Yeah, it's incredibly common.
Right. It usually masquerades as nothing more than a common cold, running through daycares and households with this kind of seasonal predictability. But beneath that mild disguise, it possesses the sinister biological ability to physically fuse human lung cells together.
It's honestly one of the more terrifying mechanisms out there.
It really is. So we're looking at an invisible assassin that claims the lives of nearly 100,000 children every single year. We're doing a deep dive into a microscopic stalker that has been hiding in plain sight right inside our own homes for decades, and exploring the thriller-style scientific investigation that finally unmasked it.
The sheer scale of its impact, especially compared to how little it was understood by the public for so long, makes it a remarkable and frankly terrifying organism.
Absolutely.
The story of how science discovered it and the tragic missteps we made trying to fight it is really one of the most dramatic chapters in modern public health.
So let's set the scene with how it was actually found, because it starts like a classic thriller movie trope. We have to transport you to a laboratory in 1956.
A very different era of science.
Exactly. So scientists are studying a group of chimpanzees that are suddenly suffering from runny noses, coughing, and just severe respiratory distress. The researchers isolate a mysterious pathogen from these animals, and they name it the chimpanzee coryza agent.
And coryza just means inflammation of the mucous membrane in the nose.
Right, basically a bad cold. So at this point, the scientific community believes they've found a new exotic monkey virus.
But just 1 year later, in 1957, the clinical picture completely flips. Virologists realized this wasn't a monkey virus at all.
Wait, really? So where did it come from?
Well, the chimpanzees hadn't brought it into the lab. They had actually caught it from their human caretakers. Yet, the pathogen was human in origin. And when researchers started looking for it in hospitals, they realized it was responsible for the massive waves of severe, life-threatening airway infections they were seeing in human babies every single winter.
It's the ultimate, the call is coming from inside the house scenario.
It really is.
We thought we were looking outward at an exotic animal threat, but we had actually just stumbled upon one of humanity's oldest and most prolific microscopic stalkers. And the true name they gave this villain is Respiratory Syncytial Virus, or RSV.
RSV, right. It's an RNA virus belonging to the pneumoviridae family, existing mainly as two genotypes, A and B.
Okay, but reading through the clinical descriptions in our sources, the word that keeps popping up is right there in the middle of its name. Syncytial. From what I gather, this means the virus is literally melting the walls between our cells.
Yes. How it does that is biologically fascinating. It comes down to a highly specialized piece of viral machinery called the F-glycoprotein.
Okay, what does that do?
So when RSV enters the respiratory tract, this F protein sits on the surface of the virus. Once the virus infects a human airway cell and starts replicating, it pushes these F proteins onto the outer membrane of that human cell.
So the human cell is now wearing the virus's machinery.
Precisely. The F protein then acts like a biological blowtorch. It forces the membrane of the infected cell to fuse directly with the membrane of the healthy neighboring cell.
So instead of millions of individual healthy cells lining the lungs, the virus creates these massive mutant multinucleated giant cells.
Exactly. Those giant fused cells are called syncytia. And because the virus is spreading by knocking down the walls between neighboring cells, it never actually has to step outside into the extracellular space.
Oh, I see.
Yeah, completely avoids the bloodstream and the airway surface where neutralizing antibodies are waiting to attack it.
It's like a burglar breaking into an apartment building. Instead of using the hallway where the security cameras, your circulating immune cells, can see them, they just take a sledgehammer and knock down the walls between the apartments to move from room to room entirely undetected.
Building on that analogy, the structural damage of knocking down all those walls is immense.
I can imagine.
The cell-to-cell spread destroys the structural integrity of the delicate airway lining. Yeah. The dead, fused cells slough off into the airway, combining with mucus to create thick plugs that physically block the tiny tubes in an infant's lungs.
So it evades the immune system while simultaneously suffocating the patient from the inside out.
Tragically, yes.
If the virus is structurally this sneaky and this destructive, how did our early scientific attempts to defeat it go? Because diving into the history of RSV vaccine development, the clinical trials from the 1960s read like an absolute nightmare.
It remains one of the darkest moments in vaccine history.
Yeah.
In the late 1960s, scientists rushed to create a vaccine using a formalin-inactivated version of the virus.
And formalin is a chemical used to kill the virus, right?
Yes. The idea was to show the infant's immune system the dead body of the virus so it could learn to recognize it. Initially, the blood test looked very promising.
Meaning the vaccinated infants produced antibodies.
They did. But winter arrived, and those vaccinated children encountered the real, wild RSV out in their communities.
The sources state it caused something called vaccine-enhanced respiratory disease. But why? If they had antibodies, shouldn't they have been protected?
You would think so. But the formalin inactivation altered the three-dimensional shape of that critical F-glycoprotein we just talked about.
Ah, so the shape changed.
Right. The babies produced antibodies, but they were poorly neutralizing, meaning they could bind to the virus, but they couldn't actually stop it from infecting cells. More critically, the vaccine triggered a flawed immune reaction known as a T helper 2 biased response.
Wait, hold on. What does a T helper 2 bias response actually mean for the baby's immune system? Is it attacking the wrong thing?
Essentially, yes. The immune system has different defense strategies. A T helper 1 response is designed for viruses. It sends in cells that cleanly kill infected tissues.
Okay.
But a T helper 2 response is normally reserved for fighting off large parasites or triggering allergic reactions. It summons a massive flood of mucus and highly inflammatory white blood cells called eosinophils.
Oh, no.
Because the vaccine primed the immune system incorrectly. When the wild virus showed up, the infant's body launched a massive allergic-style parasitic attack against its own lung tissue.
So the vaccine didn't just fail to provide a shield, it essentially handed the baby's immune system a funhouse mirror.
That's a good way to put it.
When the real virus showed up, the immune system panicked, misinterpreted the threat, and weaponized the body's own inflammation against the infant's fragile lungs.
The resulting inflammation was catastrophic. The baby's lungs filled with fluid and eosinophils. Up to 80% of the vaccinated infants had to be hospitalized, and tragically, 2 toddlers died during the trials.
That is heartbreaking.
It really is. The chilling effect of that failure froze RSV vaccine research into what immunologists call the long winter. For decades, the scientific community was terrified to test any new RSV vaccines in children.
60 years without a vaccine for a virus that infects almost everyone. If we couldn't stop it biologically for over half a century, we just had to watch it spread. Let's look at the transmission data. How does this pathogen move through a population so efficiently?
It is a master of multi-road transmission. It spreads horizontally through direct contact touching the mucous membranes of an infected person or through fomites.
The surfaces.
Right. RSV can survive on hard contaminated surfaces like cribs, doorknobs, or toys for several hours. But the respiratory routes are the most formidable. It travels in large droplets when someone coughs or sneezes.
And the sources note it also travels in fine aerosols, which are much smaller.
Yes, we are talking about particles smaller than 5 micrometers.
Yeah.
These don't just fall to the ground. They can hang suspended in the air.
Like an invisible fog.
Exactly. When inhaled, these tiny aerosols can bypass the upper respiratory defenses, the nose and throat, and penetrate deep into the distal alveoli.
Meaning the very bottom of the lungs where the actual oxygen exchange happens?
Precisely. Infection deep in the alveoli causes much more severe disease. Furthermore, we are now seeing chilling emerging evidence suggesting RSV might be capable of vertical transmission.
Wait, vertical transmission? Like from mother to baby?
Yes. This means a pregnant mother who catches the virus might potentially pass it directly through the placenta to her unborn baby in utero, which researchers believe could lead to severe developmental, neurological, and pulmonary issues before the child even takes its first breath.
That is deeply unsettling, and it does all this biological maneuvering quietly. The incubation period is typically 4 to 7 days, right?
That's correct.
So you catch it, you feel entirely fine, you go about your normal life, interacting with people, holding babies, sitting on airplanes, while the virus is already quietly remodeling the architecture of your airways.
It's basically a ticking time bomb.
Exactly. Because it spreads so silently, it inevitably finds the people who are least equipped to fight it.
The global burden really reflects that silent efficiency. We see roughly 33 million lower respiratory tract infections from RSV every single year, leading to over 3.6 million hospitalizations.
Those numbers are staggering.
They are. The populations at the absolute highest risk are infants under 6 months old, in particular, premature babies.
I imagine premature babies born before 35 weeks are at extreme risk because their lungs simply haven't finished baking yet.
Yes, they lack crucial surfactant.
Which is what exactly?
Surfactant is a slippery liquid produced late in pregnancy that coats the inside of the air sacs, keeping them from collapsing when we exhale. Without it, the lungs are incredibly stiff. Preemies also miss out on the crucial final weeks in the womb where the mother transfers her protective antibodies.
So they have zero natural armor.
None. But beyond infants, children with congenital heart or lung diseases are highly vulnerable, as are adults over 60 whose immune systems are experiencing natural age-related decline.
The vulnerability isn't just physical age or underlying disease, though. The geography of this disease plays a massive role.
It really does.
The data shows that 97% of pediatric RSV deaths occur in low and middle-income countries. This is driven by systemic environmental factors, crowded living conditions, high exposure to indoor pollution or tobacco smoke.
Which is terrible for the lungs.
Right, because tobacco smoke physically paralyzes the tiny hair-like cilia that are supposed to clear mucus out of our airways.
And most critically, there is a lack of access to basic supportive health care in those regions, like clean supplemental oxygen and mechanical ventilators, which are the primary ways we keep severe cases alive.
Before we move on to what the disease looks like, I have to bring up a wild genetic finding from our sources.
Oh, the olfactory receptor.
Yes. Researchers were sequencing the exomes of infants who suffered from severe RSV, looking for genetic risk factors. They found a specific variant in the OR13C5 gene. This is an olfactory receptor gene, a gene explicitly related to our sense of smell. Why on earth would the wiring of a baby's nose dictate whether their lungs survive a viral infection?
It completely challenges how we categorize the human body. We traditionally think of olfactory receptors existing strictly in the nasal cavity to detect odors.
Right.
But genetic mapping shows they're expressed in various tissues throughout the body, including the deep respiratory tract. In the lungs, these smell receptors seem to be acting as an immune tripwire.
So the same sensory hardware we use to smell a flower might actually be functioning as a chemical radar for detecting invading pathogens.
Exactly. Or, conversely, the virus might have evolved to exploit that specific receptor to gain entry into the cell.
That is wild.
It highlights that the human body isn't neatly compartmentalized. The same genetic variant that alters how a cell processes a scent molecule might be the exact vulnerability RSV uses to trigger catastrophic inflammation.
With genetic tripwires and physical vulnerabilities stacking up, what happens when the virus actually breaches those defenses? What does this infection physically look like as it progresses?
RSV is a disease with a dual nature. In a healthy adult or older child, it stays contained in the upper respiratory tract. You experience a runny nose, sore throat, maybe fatigue, a standard cold.
But in the vulnerable populations.
Right, in those groups we discussed, the virus drops into the lower respiratory tract. That's when you see the rapid progression to bronchiolitis or pneumonia.
And what does that look like clinically?
The clinical signs are rapid, shallow breathing, severe wheezing, and visible respiratory muscle fatigue. You can actually see the skin sucking in around the baby's ribs and collarbone because they're literally exhausting their skeletal muscles just trying to pull air through the viral blockages.
It sounds horrifying to witness. But the clinical papers reveal something even more alarming. RSV has what they call pleiotropic effects. Wait, pleiotropic? Does that mean it doesn't stay confined to the lungs? Is it traveling to other organs?
Yes, it is systemic. Severe RSV infection can attack the cardiovascular system, causing myocarditis, which is inflammation of the heart, muscle heart failure, and severe arrhythmias like ventricular tachycardia.
Unbelievable.
It can also attack the central nervous system, leading to seizures and encephalopathy, particularly in neonates.
It's almost like an invading army that lands on the beach. The lungs. But then instead of just fighting on the sand, it immediately sends paratroopers inland to take out the city's power grid, the heart, and the communications tower, the brain.
The systemic shock to the body is profound.
Mm.
And even if a pediatric patient survives this acute multi-organ invasion, the war isn't always over.
There are long-term effects.
Yes. The severe inflammation and the physical scarring from those fused syncytial cells can leave permanent damage. Epidemiological studies show these children have a significantly higher risk of recurrent wheezing, developing clinical asthma, and suffering from permanently impaired lung function well into their adolescent years.
If it's doing this much systemic damage, what do emergency room doctors actually do? I'm looking at our modern antiviral arsenal. We have Paxlovid for COVID, Tamiflu for influenza. Why don't we have a standard antiviral to just kill RSV?
Because RSV actively sabotages the cellular alarm system. It produces two specialized non-structural proteins,
Mhm.
known as NS1 and NS2.
Okay, what do they do?
Normally, when a human cell detects viral RNA, it uses an internal signaling cascade called the JAK-STAT pathway.
Hold on. What is the JAK-STAT pathway? Is that like the cell's internal 9/11 system?
Exactly that. The JAK-STAT pathway is how the cell senses the invader and subsequently pumps out interferon.
And interferon is the alarm.
Right. Interferon is a chemical siren that warns all the neighboring uninfected cells to raise their antiviral shields and stop protein synthesis. But RSV's NS1 and NS2 proteins act like cellular signal jammers.
Sneaky.
Very. They physically bind to and block the JAK-STAT pathway. The cell knows it's infected and tries to shout for help, but the virus has already cut the microphone cord. The interferon alarm never goes off.
So we don't actually have a weapon to kill the virus in a normal hospital setting. We can't cure it. We're essentially just bailing water out of a sinking boat, providing IV fluids, nasal suction, and oxygen, hoping the patient's body eventually patches the hole itself before they drown.
That is the grim reality of pediatric ICU care for RSV. Treatment is almost entirely supportive.
There are no drugs at all.
The only approved antiviral is a drug called ribavirin. However, it is highly toxic, a known teratogen, and incredibly expensive. Its use is strictly reserved for the most severely immunocompromised patients like children undergoing stem cell transplants, where the virus would be guaranteed fatal without it.
Because treating the disease once it's severe is so incredibly difficult, public health realized the only way out was to stop it before it ever enters the body. Which brings us to the end of that 60-year-long winter of vaccine research.
The scientific renaissance we are experiencing right now is staggering. In 2023, the FDA finally approved the first safe, highly effective RSV vaccines. The most fascinating approach is the maternal vaccine, known commercially as Abrysvo.
I was reading about this mechanism. Instead of vaccinating the baby directly, which is risky because their immune systems are still developing, they vaccinate the pregnant mother between 32 and 36 weeks of gestation.
The timing is critical. The mother's mature immune system processes the vaccine and generates a massive surge of highly neutralizing antibodies.
And those go to the baby.
Yes. During those final weeks of pregnancy, the placenta acts as an active transport mechanism, pumping those antibodies directly into the fetal bloodstream. When the baby is born, they possess robust passive immunity that covers them for their first 6 months of life, their most vulnerable window.
It's like a mother forging a custom-made suit of microscopic armor and dressing her baby in it before they even leave the womb.
Beautifully said.
But not every mother has access to prenatal care, and premature babies miss that antibody transfer window entirely. How do we protect the infants who don't get that maternal shield?
That is where the second major breakthrough comes in next-generation monoclonal antibodies.
What was the old generation?
For decades, the only option was palivizumab. It was an antibody injection, but it degraded quickly in the body. It required a painful injection every single month of the RSV season. It was so astronomically expensive it was strictly rationed for only the highest-risk preemies in wealthy nations.
But the sources indicate a new drug, nirsevimab, has fundamentally changed that math.
Nirsevimab has an engineered protein structure that allows it to survive in the human bloodstream for months. It is a single long-acting shot given right at birth or at the start of the winter season.
And it works well.
Real-world clinical data shows it reduces severe RSV hospitalizations by 62 to 74%. It is currently transforming the landscape of pediatric medicine, keeping thousands of infants out of the ICU.
With these biological shields finally arriving, we still have to manage the physical spread of the virus in hospitals and daycares, especially considering the symptoms mimic so many other diseases.
Infection control remains paramount. This means standard contact and droplet precautions, rigorous hand hygiene, isolating infected patients, and improving indoor ventilation. But the linchpin of hospital infection control is rapid, accurate diagnostics.
Because RSV looks exactly like a terrible bacterial chest infection to the naked eye, and that creates a massive clinical trap.
Yes, it does.
Without a rapid swab, a doctor seeing a wheezing, feverish infant might panic and blindly throw heavy antibiotics at them.
Which does absolutely nothing against a viral infection.
Right.
All it achieves is wiping out the infant's healthy gut microbiome and breeding antibiotic-resistant superbacteria in the hospital environment. That is why multiplex PCR testing and rapid antigen tests are crucial. An emergency room physician needs to know within minutes whether they are fighting RSV, COVID-19, or influenza A, so they can deploy the correct isolation protocols and avoid useless antibiotic prescriptions.
And on a macro scale, surveillance networks rely on those same tests. I note that the World Health Organization has formally integrated RSV into its Global Influenza Surveillance and Response System, or GISRS.
A vital step.
They are using global data to track strains and predict outbreaks. But a radar system only works if the target behaves predictably. And recently, RSV completely stopped following the rules.
We are operating in uncharted epidemiological territory. Historically, RSV was remarkably predictable. It peaked reliably in the winter months in temperate zones like North America and Europe, and surged during the rainy seasons in the tropics.
So what changed?
In 2020, the behavioral changes triggered by the COVID-19 pandemic lockdowns, masking, closed schools, and global social distancing suppressed RSV circulation by an astonishing 98% in some regions.
But the virus didn't go extinct. It was just locked outside.
Exactly. And by keeping everyone isolated, we inadvertently conducted a massive, unplanned experiment on human immunity. A recent Canadian immunological study tracked adult populations before, during, and after the lockdowns. What they discovered is that human immune systems actually rely on constantly being re-exposed to circulating RSV in the community just to keep our neutralizing antibody levels topped up.
It's a fragile ecological balance. We locked our doors so the predator couldn't get in, but when we finally walked back outside a year later, our immune systems had essentially forgotten how to fight.
That phenomenon is known as immunity debt. When society fully reopened, RSV roared back with unprecedented ferocity.
Oh.
We saw terrifying out-of-season summer outbreaks.
I remember reading about that.
Pediatric ICUs were overwhelmed with toddlers who had never been exposed during their first years of life, while the parents caring for them were getting severely sick because their adult antibody levels had plummeted from lack of natural boosting. It took 2 full, brutal cycles of rampant community reinfection for the population's baseline immunity to stabilize back to pre-pandemic norms.
With the old seasonal rules broken and these new protective vaccines finally hitting the market, what does the next decade of RSV research look like?
The clinical pipeline is robust.
Huh.
There are currently 24 different RSV vaccines in various stages of development. Scientists are leveraging the same cutting-edge mRNA technology that revolutionized the COVID-19 response.
Oh, that's promising.
Additionally, researchers are heavily focused on live attenuated intranasal vaccines, essentially a weakened virus you spray into the nose. The goal there is to build mucosal immunity right at the site where the wild virus first attempts to enter the body, stopping infection before it even begins.
But engineering the perfect drug is only a fraction of the battle. The data clearly states that 97% of pediatric RSV deaths happen in low- and middle-income countries. A brilliant, highly effective mRNA vaccine does absolutely nothing for a vulnerable child in rural sub-Saharan Africa if the drug costs hundreds of dollars a dose and requires ultra-cold, deep-freeze storage to remain stable.
The ultimate hurdle is global health equity. Public health organizations realize this. The global focus is shifting heavily toward organizations like Gavi, the Vaccine Alliance.
What are they doing?
Their 2026 to 2030 strategic plan is intensely focused on pooling international procurement to drive down manufacturing prices, establish equitable supply chains, and get these life-saving monoclonal antibodies and maternal vaccines to the regions that suffer the highest mortality rates.
It is an era of incredible progress after decades of waiting in the dark. But looking at how interconnected our immunity is with the virus's circulation, the science leaves me with a provocative, slightly unsettling question to ponder. Well, the post-COVID data showed that adults actually rely on constantly catching mild RSV from their community just to keep their immune memory strong. So what happens if our new, highly effective vaccines successfully interrupt that community transmission? If we stop the virus from circulating widely, will our collective natural antibody levels drop again? Will our modern biological shields inadvertently recreate the exact same dangerous immunity debt we suffered during the pandemic lockdowns?
That is precisely the million-dollar question keeping public health modelers awake at night. It dictates that our global surveillance systems have to be sharper than ever. We have finally built the scientific weapons to fight this invisible stalker, but we have to be incredibly vigilant about the unintended ecological shockwaves we might create when we deploy them.
An invisible stalker that has been in our house all along, melting our cells, evading our alarms, and forcing humanity to walk a fragile biological tightrope just to survive it. Stay informed. Stay prepared. This has been Outbreak Brief.